So this is week 6. We are halfway through and it's going to start getting pretty rough. There's more and more homework due. You've got projects week 8. You've got exams week 7, week 10. Then you've got community, med surge, and it's going to get pretty harried. So try to keep up with what's going on. I do appreciate everybody telling me I didn't see this or that. I tried to do this. I couldn't get into it. It alerts me to I'm not perfect, but I try to, when you do things, I try to correct them as soon as I possibly can. So if you let me know what's going on, I can help you. Now, last week we got a message from Dean Brown about, this, and that. I want to tell you, 4 of my classes, I have no problems. Your attendance is good. You stay with me. Most of all, your cameras are mostly on. And if they're not, I usually know why. So I appreciate you for doing that and being so professional. Okay. That tells me I've got a group, all of my classes, of some great RNs that are going to be in the future. So thank you for being as good as you are. I do appreciate that. I think you all realize I work hard to give you what you need and to give it in an understandable way. I'm always going over PowerPoints, always going over Cahoots, making sure information is there in a way that you can understand it and use it. I do caution you, don't memorize things, okay? Look at it and try to use it in a different way, okay? Because that's where you'll get into errors. And I know there's so many cultures here, and I know some cultures don't understand things as well as others, and if you're having a trouble with it, remember there's a book to read also regarding these things. Maybe that'll help you a little more. So as you noticed, I did turn on the homework grades, which means I've turned on NCLEX questions and I've turned on your case studies. So if you didn't do good on them, your homework grade probably was affected. These stay on through about week 8, and then I turn them off again. They will not come on until after your HESI remediation, until they're all done, which means week 12, Tuesday, is the first time you'll see your final grade. So just keep up with your homeworks. Now, I've had people contact me, things happen, no battery ran out in a computer, or this happened, a thunderstorm, an ice storm. I couldn't get my exam done, quiz done. Just let me know right away. I can work with you. Another thing I've heard, especially after exam 1, people are saying that they had 2 exams back to back. Just let me know. I can work with you. If that happens again, remember, I have 4 classes. Plus, I have another 13 pediatric classes. I can put you somewhere else one time, okay? If it's like you are flipping out, you can't get it done, you're stressing, let me know. I can work with you. I understand back-to-back exams are rough, especially if it's community, which you're trying to understand, and then med surg too, which is extremely difficult. Okay, so just let me know. I can work with you, okay? So this week you have 2 case studies, your congenital heart disease and cystic fibrosis. You have your NCLEX questions that are due. And remember, you do have exam next week. Exam reviews did start today. I did send you out the PowerPoint study guide. And you do have exam reviews on Wednesday by Professor Okorafor. You have me on Thursday at 5 p.m. You have Professor Gullett at Friday at 12 noon. And then you have Professor Morris at 10 a.m. on Saturday. So they're all over the place. I think that these exam reviews will give you plenty. I will post all of them, okay? And remember, my YouTube channel is open. You can go and look at, let's say, last semester's. Maybe I say it differently, but there are some changes. Just remember that there isn't completely the same exam. We always do at least 10% changes on every exam that you take, okay? So today, what are we going to be doing? like we always do. I'm going to give you your PowerPoint, and then I'm going to give you your cahoots, okay? I hope my voice keeps up with you, because I was telling the earlier students, I've been sick since last Tuesday night, and it's all with my voice and my throat and coughing. So if I start to cough, I'll go on mute, because I cough and it's hard to get stuff up type thing. So I've taken Robitussin and Dayquil. They both have Robitussin, that guafsin in it. So I'm a little loopy, but it is coming up easier, but I'll put it on mute so you don't have to listen to me. Okay? So any questions, any concerns? Remember, anybody who has any issues regarding last week's type of information that I was giving you, if you need more clarification, let me know and I'll go over. I've heard from one class, it's all about tetralogy of Fallot and also PDA are two things that they were confused about. So if you need to understand them, yeah, you're going to see them again. So please let me know. So let's start with our PowerPoint. Hematology, immunology. It's a lot of different stuff here, and it can get confusing. So, and it's what do we do with these sort of conditions? Well, we know hematology is blood. Well, so is immunology. It's your lymph nodes, it's your white cells, it's how to fight infection. So how do we first look for dysfunction? Well, take blood. Let's look at your white cells. Let's look at your T cells. Let's look at your hemoglobin hematocrit. Now, one of the most common things that we see in hematology is iron deficient anemia. Most common, right? You've heard of that, even if you've not in nursing school. And what is iron deficient anemia? Well, your body produces hemoglobin, and that produces, this is red blood cells. And red blood cells, what do? They carry oxygen and nutrients to the cell. If you don't have red blood cells, you're not going to get oxygen somewhere. And if you don't have enough oxygen, what happens? That gives you energy, right? If you don't have oxygen, you're going to be tired easily. And that's probably the biggest thing that we will see, is that being tired. And it's a complaint that usually parents bring their kid in. My kid doesn't act the way it should. It's lack of energy, right? Now we know children as they start growing. I mean, infants, we can sort of give them their milk, their formulas, the breast milk, and their iron is okay and iron supplements. As they get older into toddlers, we know that they go into that physiologic anorexia, and they don't want to eat, so they're not going to get iron. And are they going to eat those iron fortified food? Do they like broccoli? I mean, there's not many kids who's going to eat broccoli, except my grandson. That's all he wanted was broccoli as a toddler, but he was weird, okay? Most kids aren't. Another thing we see with immunological dysfunction is those frequent infections. It just means the immune system isn't working well. And then the other thing with hematology is bleeding, and we're going to go into those things. So red blood cells, like I said, the most common hematological order is that iron deficient anemia, and that is a decrease in the number of red blood cells. So oxygen is low, like I said. Why does it happen? Well, there's many different things. We know it's because you don't have red blood cells for many different reasons. They're not there. And we're going to go into those sort of conditions. We say, as in pediatrics, that a hemoglobin less than 10, we consider that anemia in children, okay? I mean, in adults, it might even be a 9. So here's our sort of anemias. Well, you can have decreased red blood cell production, or an increased loss of those cells, or increased red blood cell destruction. And there's signs and symptoms of it, but all of these you're going to see that fatigue, that tired, and that's usually the first thing that brings you in. Now, nutritional, iron deficient anemia. Well, you're not eating right, or your body can't absorb that iron. That's number one, as I said. It could be B12. That's your intrinsic factor, right? You cannot absorb nutrients. You're not going to get your iron that you need. Another thing could be that bone marrow failure. So you're not getting enough red blood cells produced. The biggest one we see is aplastic anemia. And we're going to go into that more. And what does that mean? Your bone marrow is not producing those red blood cells. And I'm going to show you what we need to do for that. Of course, if there's something like leukemia and a cancer, that can cause it too. Now, increased red blood cell loss. Well, the first thing we think you're losing blood, that's hemophilia, because you're bleeding. I mean, even brushing your teeth could cause bleeding and losing of cells. A young woman, adolescent, even when she has her period, right, her menses, they could bleed too much, and that could cause that also. Another thing is called ITP, and we're going to go into ITP is idiopathic thrombocytopenia purpura. We'll say that 3 times quick. Just think ITP, think P platelets, okay? Just remember that, ITP, P is platelets. And then we have increased red blood cell destruction. Well, we've all heard of sickle cell anemia, and we're going to go into that's the loss of cells. They're irregularly shaped, and we lose them, and they're destroyed quickly. And then there's thalassemia, and we're going to go into different sorts of thalassemia. And then we have the immunologic, where you're could be drugs, toxic substances, etc., or even acute infections. Now, what happens with anemia? What are we going to see? Well, besides seeing the symptoms of fatigue and being tired, when we go to listen to this child, even adults, we listen to their, breath sounds. We're going to listen to their heart. Well, their heart, we're going to have, the cells are very few. So there's a lot of swooshing going on in there. And you're going to be hearing a murmur, which is not normal. If a child or adult's never had a murmur before, you're going to say, something's going on, and you're going to figure it out. Also, we know that blood cells tend to go to where they're needed, so you might see some cyanosis going on. And if it's prolonged, you're not getting nutrition and oxygen to the cells. You're not going to grow correctly. You're going to be, it's just like not getting enough nutrition. It's just something that you will see. So how do we figure out anemia? Well, of course, the history physical, we're going to do that blood. We're going to do that CBC. Now, we can go ahead and just give blood and blood and blood, and we don't know why, but we're just treating the symptom. We don't need to do that. We need to find out what is causing the body not to produce enough red blood cells. Well, after we figure that out, if it's nutrition, we'll change it. If it's iron, we can give iron or change the diet. Now, if it's really low and the child's really, tired, etc., we might admit them to the hospital. We might give them fluids just to help them, with that intravascular space. And it's sort of questionable about oxygen. If you don't have cells to carry oxygen, is it going to work? But we're going to put them on bed rest, so they're not expending any energy at all. Now we're going to assess the child. We know sickle cell is what? African American is the highest level of sickle cell. So it might be something that we look at. And we're also going to rule out, is it bleeding? A GI bleeding. So we'll do a stool for occult blood, because it could be as simple as that. Remember, kids have to get a blood test. Whether it's the prick of a finger or sticking a needle in an arm, we need to prepare them. And we need to make it as comfortable as possible. Have parents hold their child. Put some numbing cream on so they don't feel the pain, okay? Because if they're already severely anemic, all that getting upset is going to burn a lot of energy for them. So iron deficient anemia, we know infants, we do give them iron fortified formula and cereals. So we know that they're getting enough. But as they get older, they're going to need something else, most likely. We know that when they turn at 1 year old, they can have whole milk. Are they getting the iron from the formula? No. So we need to increase somehow, give them what they need. So this is most likely either that change in diet, or if that don't work, give them some iron, whether it's iron dextran, IM injections, or liquid, depending on the child. Sickle cell anemia. We know that African American are the carriers. We know that if both parents have a trait of sickle cell, doesn't mean they have it, just means they carry the possibility of passing it on to a child. So if both of it have it, that child, each child, has 25% chance of getting the disease. So what is sickle cell? Well, sickle cell is those sickle-shaped cells. And what happens is when those vessels bifurcate and they split in 2 or 3, they sort of get hooked and they can't go through. And their one cell stops the blood flow from going down. And then all the cells back up behind it. So it swells. And what it does, it causes inflammation. Those cells die and swelling and pain. And it causes local hypoxia, and it could cause death of tissue in that area. And it's usually the pain that brings this child to the doctor. Now, what causes sickle cell crisis? Well, anything that causes the body's need for more oxygen, whether it's, physical, emotional stress, trauma, infection, how about fever? All of these things, what it does, it causes the body's blood to be more thick. We know it causes, it's like a dehydration. So when your blood volume becomes less and it gets thicker, these cells can't get through vessels, okay? So what do you think the first treatment would be in order to get blood to flow through the hose, through the pipe? We need to thin it, right? So we can push it through. So number one, we're gonna give IV fluids, number one. Now you're gonna say, well, sickle cell hurts, must be give something for pain. Well, what are you doing? You're treating the symptom. Let's take care of the cause first. Now, it doesn't mean you're not going to start an IV, give a bolus of fluid, and give pain medicine at the same time, but your first treatment is that IV fluid. Let's dilate the vessels. Let's let those sickle cells try to get through. We're going to put heat on the area, dilate those vessels, try to get the sickle cells through, and that's going to alleviate the pain. We know that, we have issues with electrolytes. We're going to be checking them, replacing them as needed. And if those blood counts are really low, because remember, sickle cells die quickly, so your body can't keep up with it. I mostly see with children coming in with sickle cell crisis attacks, wherever it is, an arm, a leg, a knee, an elbow, whatever. I know that their hemoglobin hematocrit could be as low as 5 and 15. I know most likely that child is going to be getting blood most of the time. First of all, we're going to give IV fluids. We're going to take care of the pain, replace those electrolytes, and then we're going to be giving the blood. Now, most of the time they're coming in because they've had an infection. It's mostly what I've seen with sickle cell, the smaller children. The adolescents, a lot of times it's the stress, being in high school, trying to get good grades, the emotional of the boyfriends, et cetera, right? So they will be getting, antibiotics, the younger kids. Now, younger kids, ages 2 months to 5 years, we give a prophylactic antibiotic, 1 pen-VK per day, and it's prophylaxis. Now, we're also going to be monitoring the reticular count to see, is the blood marrow still producing red blood cells? How quickly are they producing them? So we know what we need to do. And we know we're going to give blood transfusion because those blood cells have oxygen in it. We're giving the body the oxygen and the nutrients it needs in order to be healthy, to reduce that ischemic episodes. That means not enough oxygen to the brain. We're going to keep that patient alert, oriented, and the organs getting the oxygen they need. Now, there is no cure. It is an immunosuppressive disease. So we know that these children must be very careful around other children because they're going to be catching diseases easier because their body's just trying to keep up with red blood cells. It doesn't have that ability to keep up with infections also. But children with sickle cell disease can grow up into be adults as long as they treat themselves, seek attention when they're having these pains, keeping themselves well hydrated, and knowing their bodies. So early intervention, giving the penicillin. And one of the things we don't think about with sickle cell is it can be a sickle in the brain, okay? Vessels in the brain could get occluded. And what does that cause? It's a stroke. So you have a kid coming in with a headache with sickle cell, do a neuro check, number one, right? Because it could be the head. Pupils, look at them. How are they alert, oriented, moving all extremities? Is it all equal? And then, of course, it could go right to the lungs. And of course, that would sort of mimic like a pulmonary embolus, wouldn't it? It'd be that occlusion of some sort of blood vessel there. So we are going to try to prevent sickling. We're going to try to treat that kid normally. If the kid wants to play sports, that kid's going to be well hydrated, most likely with Powerade or Gatorade, one of those to keep the electrolytes in them. And the child needs to understand that's what he needs to do in order to be normal, in order to be able to do the sports they want to. Now, sickle cell is a sickle-shaped cell, right? Thalassemia is a rectangular shaped cell. But what happens is these cells, they're not shaped right, they're malformed, and they're very short, and they burst, okay? And the insides of that cell bursts into the blood system. Well, what's in a red blood cell? Iron. And if too much of these red blood cells burst, and there's too much iron, that runs into other problems. Now, whereas sickle cell was African American, thalassemia is from the Mediterranean Sea, descendants, that's what they say. Now, there's all types. It's like mild, medium, and like severe. Now, Cooley's anemia is a severe. And because of the amount of cells bursting and putting iron into the system, and oxygen is going away, right? They need transfusions to survive. Whether it's weekly, monthly, it all depends on the child and how much cells are bursting. Now, sometimes we can see them in infancy, and we'll see that first with their hemoglobin hematocrit's low. And then we start looking at the cells, and in a blood smear, we'll see that. At 6 weeks of age is when we start to see it. How would we know? Well, your body's not getting oxygen, not getting the iron that it needs in the body. It's going to be anemic. They're going to have growth failure. The body's not getting the nutrition it needs to live. So it's like no nutrition, because that's what the red blood cells do. They give nutrition to the body. So these children will need blood transfusions to maintain normal levels. Now, I've talked about all this iron going into the system. Iron can be extremely toxic, okay? At this level that you need to have blood transfusions to live, iron being spewed into the body needs to be taken care of. You need to remove it. And there's two ways. There are iron chelating drugs. This Desferil is one of them. And what it does, it goes and it combines with the iron and you excrete it. We also use something like a dialysis machine, but it's called apheresis. And you can pull out certain components of your blood and get rid of it. And you can get rid of iron that way. Some children, which turn into adults, need that, the machine, the apheresis, and it does, you hook up just like a dialysis machine, but it only gets rid of that component, the iron. So care management. Well, this child's going to be constantly poked, prodded, given iron, constantly hooked up machines, has to take medicines, you know, is always going to be tired, again, immunosuppressed, they don't got an immune system. And, you know, this child is not going to be as normal as they'd like, because they do have to, you know, do all of these things to be able to live. You know, it is not just the child, the family has to adjust to this, because they have to make sure they get to the appointments, they get their blood testing. The child has to know it's going to be constantly poked and prodded for this and the reasons why. And it's a very difficult disease for the child and the family. Now, if they take care of themselves and if they get the treatment they need, they can live into adulthood. But remember, what's the complications of anemia? It's a chronic state. They're always, right before a blood transfusion, they're anemic. So it's anemic, not anemic, anemic, not anemic. The heart goes into failure. The organs don't get what they need, goes into failure. Sometimes they take the spleen out because they don't want the cells made, because they don't work anyway. And sometimes because of their immune system, they go into failure. Maybe they're not sure, bone marrow transplantation is a cure. Now, aplastic anemia, as I said, this is a decreased production of red blood cells. Now, their red blood cells are not produced the way they should, but their white blood cells and their platelets are okay with this hypoplastic anemia. But in pancytopenia, all elements of the blood are depressed. Red blood cells, white blood cells, platelets. What does that mean? Well, you don't have oxygen, you don't have iron, you don't have a white cell, you don't have an immune system. And platelets are a big component of blood coagulopathy. It helps bleeding, it helps stop bleeding. Not enough platelets, you can bleed. So how do we treat aplastic anemia? Well, basically what we do is we give immunosuppressive therapy to these children. We give them a bone marrow transplant. We try to make their body do what it's supposed to do. Now, problems with bleeding, hemostasis. That means you have to, if you get a cut, you want hemostasis, that will stop the bleeding. We know that there's platelets there and there's clotting factors. And when we think of bleeding, we think of hemophilia, right? Now, there are several types that we talk about. Hemophilia is X-linked. Mom, it gives this to the child. It's inheritable, but it's an X-linked recessive gene that is given. And when we see bleeding going on in hemophilia or suspect it, we know that we're going to be sending off a lot of blood things to check out what type of blood factors are missing. Now, we think the normal hemophilia is factor 8, but there's also a factor 9, and there's also a von Willebrand factor. That's the doctor who found this factor. We didn't name an 8 or 9 or 10. He wanted his name. So it's von Willebrand. So all of these are all treated the same. They're all bleeding problems. So when a child bleeds, they will continue to bleed unless they get a factor. So how do we figure out a child has hemophilia? Well, if you have a kid whose, teeth are always bleeding, nose is always bleeding. In fact, a lot of times, nosebleeds, chronic epistaxis, is what brings a child into the doctor, their pediatrician. And they're going to say this is continuing. They'll try little things to correct it, but when it continues a lot, then they're going to do the blood test and they're going to check for it. especially if we start seeing a lot of bruising, ecchymotic areas, or if we see they fell down and their knee, is full of blood, hemoarthrosis. So hemophilia, children will fall and their knee, their wrist, whatever, elbow will get bleeding in there. And it keeps bleeding until we stop the bleeding. And that's usually when we try to do is give the factor. I mean, what do we do when a kid's bleeding? We're going to go into that the next slide. But when we're looking for hemophilia, what are we going to look for? Well, we're going to find a factor low, whether it is 8, 9, or von Willebrand, okay? And we know when we look for heparin, don't we look for the PTT level, right? Or the APTT level, that's heparin. We want to see how thin the blood is. Well, your prothrombin time is normal, but your PTT or APTT is prolonged. And then you'll see one of these low levels. Platelets are good. So that part of your bleeding coagulopathy is good. And these other ones are part of coagulopathy too, and help with making the blood clot, but you don't have a factor. But that prolonged PTT, they're not on heparin, aspirin, anything. That's going to be the first clue. So you fell down. What are you going to do? Well, you're going to do that RICE. You're going to rest, ice, contain, and elevate. If it's a knee, an ankle, whatever. And you are going to be given home infusions. Now, I've actually had young children. There was this little boy who came in with his daddy into the ER. It was a weekend. They couldn't get a hold of his hematologist. And he had been bleeding. He fell down. And you could see his knee was swollen. So you knew that he had some hemarthrosis. There was blood in his joint. And it's destructive. Blood in a joint is destructive. So he didn't know whether to give medicine. So he came in and he brought his factor 8 with him. And the physician there said, yeah, you should give it. I actually watched this father prepare, and him and the son picked out the vein to use. The child they just used a butterfly, which we don't really use a lot, for administering meds. But with this at home, they do. He actually held the butterfly while the father pushed in the factor 8. And I had this orientee with me, and she was like, wow, that was great. And I just watched. I wanted to see what the father did. I didn't interrupt, and he gave it as well as I could have done, probably better, because the son worked so good with him. Sometimes if you're lucky and have only mild hemophilia, there's a nasal spray you could do, or could be desmopressin. Well, desmopressin, have you heard about that before? Isn't that given for diabetes insipidus? That's next week's lecture. It can be used for 2 different things. So how do we manage hemophilia? Well, we're going to protect them from bleeding, right? Protect safe environment. Putting, something on the edges of coffee tables so that sharp, they don't get it. Making sure they don't have sharp objects, younger kids, that they can hurt themselves. We don't want that to happen. Soft toothbrushes, right? And then again, if something happens, we're going to RICE immediately. Number 1's protect, and then rest, ice, compress, elevate, and then give the home treatment for bleeding, whether it's factor 8, 9, or whatever. And of course, we're going to protect this child. The reason why we're so aggressive with this RICE is because that blood in any joint, a finger, an elbow, a wrist, a knee, can cripple a child with hemophilia, and they'll end up in wheelchairs if we do not protect those joints. And of course, we're going to do genetic counseling to see where it came from. And then parents will have a decision on having another child or not. So as I said, prognosis, they can live really good as long as they keep those joints protected. There is right now some gene therapy being worked on, but it's not quite there yet, almost, okay? I hope they get it soon, because these children need to be kids, and they need this gene so that they can be more normal. They can, not be as concerned with falling down and bleeding, right? Now, immune thrombocytopenia purpura. This is ITP. What did I say about this? P is platelets. Now, ITP is when your platelets are very low. Everything else is good. It's usually something that happens acutely, and it usually goes away, but it can turn into a chronic condition. It's usually after an upper respiratory infection. So how do we treat ITP? Well, many students get confused about ITP and sickle cell. Well, sickle cell, we give fluids, right? ITP, no, we don't need to. There's no clogging up in the vessels. All you get is these petechiae, these parents come in and say, this kid just plays video games, and look, he's getting these nosebleeds, and look at his legs. You're full of all of these little petechiae, or these little bruises, they call it. And we're like, what do? We do a CBC, right? Now, these children are usually admitted so that we can give them IV immunoglobulin, and we give what we call anti-D antibody. So it's more of an immune thing we give. Immune thrombocytopenia, right? Immune. So it's IV immunoglobulin. Now, when they're admitted, remember, low platelet counts, you're going to bleed. So what are we going to do as nurses? Well, we're going to, of course, teach, always. We're going to keep a protective environment, absolutely. We are going to give no IM injections. What's going to happen if we give an IM injection? No platelets. It's going to bleed, and it's not going to stop because you have no platelets. Normal platelets low is 100,000. These kids could be 10,000, okay? It doesn't matter any kid who has low platelets, and you'll see this also in cancer and leukemia. These ones you'll put on bleeding precautions, which is avoid venipuncture, monitor them for bleeding, soft toothbrushes, and we're going to be monitoring their blood counts. We're going to see where are their platelets. Sometimes we do give corticosteroids. Sometimes steroids do help with this. Nosebleeds, I've talked about this a couple times. Sometimes they're transient due to an upper respiratory, and there's no problems. But if it continues, you need to go looking for that bleeding coagulopathy, whether it's your hemophilia, your ITP, whatever it might be. It could even be leukemia that you're seeing, because leukemia, you'll see, as I said, low platelets. So how do you take care of it? Finger and thumb, hold it, sit them forward, and keep it there for 10 minutes. And we put them forward because we don't want them swallowing blood. They can spit it out if they need to, okay? If it continues, they need to go get help in either, usually your urgent care or your ER is the best place, because active bleeding needs a really proactive treatment. Could be even stuffing their noses, with what we call nasal tampons. And it helps put pressure and stop bleeding. Now, HIV and AIDS, we know that adults get it. We know that infants can get it. We know even your children can get it for many reasons. Let's talk about the infant of the mother who has HIV. Now, I've seen many different cases of mothers with HIV and different outcomes of children. Now, what they say is our goal when we know mom has HIV is to make sure that newborn, that we improve their immune function. How do we do that? We do that by this active antiretroviral therapy, or giving antivirals to the mother when they're 22 weeks along, and we continue it after birth. Okay, what have I seen in HIV/AIDS? I've seen a mother deliver triplets. One was normal, no HIV. One had HIV and the other one had AIDS. Okay, all different levels. I've seen children born with HIV and in the first year of life converted to zero HIV through the use of antivirals. So there is a chance for newborns of HIV parents. Did you know that? This is something that I didn't know when I started to work in the newborn ICU many years ago. And this is back in the late 90s to early 2000s, when they started to realize that we could convert these infants by improving their immune function from 22 weeks. And if we don't even get that immediately at birth, we will be treating them. So when we have an infant, the respiratory illness that you see that opportunistic is what we call PCP pneumonia. That's your respiratory thing. And again, we're going to be monitoring their oxygen. We're going to be giving the antivirals, and we're going to just try to maintain them during these times. I mean, there's other things they can get. They can get yeast, fungus, but I think PCP pneumonia is the most dangerous of all. So what do we do with HIV in the pediatric population? Well, newborns, we're going to do everything to improve their immune function. Adolescents, we're going to be counseling, washing their hands, using condoms, abstinence if we can for HIV. And we know that with HIV, there's a lot of confidentiality there. And this is when we're going to use that good adolescent communication, getting on their level, talking to them, that maybe we can find something out. And maybe they have HIV and they're afraid to tell mom and dad. At least we can get them into treatment, because they can live a long life today. So how do we manage a lot of these hematological and immune disorders? Well, we've already talked about transfusions. We know that there's a big protocol in order how to give it. And remember, if you have a child who needs a blood transfusion, and we do the vital signs, we come back in those 20 minutes later, and we see a fever, or we see a rash, or shortness of breath, the first thing we do, turn off the infusion, right? And then we call the physician. I told you apheresis, which sort of looks like that pump over there in this picture. And what it does, it will just remove whatever part of the blood we don't want there. Now, we will do many times blood marrow aspirations. Now, this goes into the bone, hip bone or the sternum. They do it many different places, depending. Older children who understand, you need to tell them, and they will be sedated. They'll be given pain medicine. They'll be using numbing, on the skin, EMLA cream for half an hour before, an hour before, numb it good. And then numbing as we go deeper, but let them know there might be a little pain, but she'll do everything possible to make it as little as possible, okay? So when they both have a sickle cell trait, mom and dad, what's the chance of the child to have it? Anybody?
25.
It is 25%. Thank you, Douglas. Okay, let's go into some neoplastic disorders. We know a lot of these cause you to be immunosuppressed too. What's great about today is most children do survive leukemias and lymphomas. The advances are amazing, but it is quite an ordeal to get there. And it takes a lot of support from nurses in order to get those parents through it, because it's rough to see your 2 or 3 year old daughter or son go through all of these things, and you hurt for them. Most all of the, well, over half the cancers are blood or blood forming organs, leukemias, lymphomas. Now, leukemia is a problem with white blood cells. It is a malignant disease of the bone marrow and the lymphatic system. We know it is a lot of white children, more frequent in boys greater than 1, and you usually see them ages 2 to 5. Survivability is actually pretty good. The definition of leukemia is an unrestricted proliferation of immature white blood cells of blood-forming tissues. So you're producing white blood cells, but they're immature, they don't work. So they're not fighting anything. So these children are sick. They come in usually anemic, usually with fever, usually with bone pain. Usually their platelets are low, so you'll see bleeding, like you'll see ecchymotic areas on them. You will see the liver and spleen also affected because these are white blood cells. So I had a next door neighbor. I'm going to tell you a story so you can remember leukemia and symptoms. I had a next door neighbor. She was a girl. She was older though. She was 14, I believe, at the time. She had some bruising. She had fever. She was just tired, didn't feel well, and her knee really hurt her. And her mother took her to the emergency room. And with all those symptoms, they did a CBC. And what they found is she had a white blood count of 0.1. Normal is what? 5 to 7, 7 to 10. I mean, it's a number, not a point number. So she had to go through the treatment. So what did they have to do? Well, they do a lumbar puncture to see if it's in the central nervous system already. And they're going to do a bone marrow. They want to know what sort of cells are being produced. So they're going to look at it. And again, they may experience pain. We'll do everything to make it as little as possible. You know, kids, they want to know for truth. And especially in something like leukemia, which is a long-term treatment, they want to know when it's going to hurt. Now, we've decided it's leukemia. We decided that it needs chemotherapy. There are different levels of therapy. We call them 4 phases. The most important is the induction. This is the initial 4 to 6 weeks. And they try to put this child in a remission in 4 to 6 weeks, which means they hit them with every chemotherapy they can to eradicate everything. So the goal of induction therapy is remission, but they keep going on to ensure every cell has been killed. They're going to do some intrathecal, they'll insert chemo into the central nervous system. They're also going to do ongoing therapy to make sure these cells are gone. And then they do that maintenance, which preserves that remission. So the first 4 to 6 weeks are the roughest. You can see that already. But hopefully they'll be in remission afterwards. And then it's just getting rid of this one and that little cells. Now, leukemia, we can do a stem cell transplant. And there's different types. Now, the thing about leukemia and this stem cell, you don't have to have the blood type. You know, you need blood, you need, if I'm an A, I need an A positive, okay? That's my blood type. In this, we don't look at that. It's matched or mismatched, doesn't matter, okay? Could be relatives, non-relatives. This is not that plays any sort of decision in using it. Now, there's 2 types though. Now, many parents today decide to keep the umbilical cord blood, and there's some great cells in there, but it's expensive to keep. And it, you know, as an ongoing to keep it for how many years until they need it, right? If it's their own cells, it's called autologous. I call it automatically mine, right? Automatic, it's mine, okay? Allogenic is somebody else's. It's all, everybody's, all. Okay? So autogenic, automatic, mine. All is everybody. Everybody is all, right? All of us, everybody. Now, when we get these transplants, the biggest thing is, again, rejection. And we call it graft versus host disease. And I've seen children get these graft versus host in different things, like in sickle cell, I've seen it. They do it also. And one of them, I saw a young girl, her face felt like it was on fire, like if she was a 20 out of 10 pain. And her face just felt like it was burning off. And it was that stem cell that was fighting against her own body. And of course, if it's fighting your body, you can have severe organ damage. So how do we treat leukemia? Well, as I said, this is an ongoing, almost 2 years of treatment from the very beginning to the end with all this prophylactic treatment for remission, et cetera, et cetera. So this little girl that my neighbor, she was in pain. So absolutely, we were going to medicate for pain. Don't be shy giving pain medicine. Don't under-medicate. These kids have real pain. Our biggest thing is, remember, these are white cells. There's no immune system. So infection is huge. They don't have, these children usually get blood transfusions, platelet transfusions. I mean, you have a child with leukemia, you could have platelets of 5,000. Bleeding precautions, because they can hemorrhage, even with brushing teeth. You're going to be monitoring them for bleeding. And as I said, anemic because of their count so low. And as nurses, you have to be careful with these chemotherapeutic agents. You know, today, nurses who want to work with cancer in children and get trained, do you realize sign-in bonuses on many hospitals are up to $25,000 sign-in bonus? That's how specialized this is. Yes, it's a hard area to work, but it is rewarding in many ways. Now, not all kids going to make it through any illness, okay? Some of them die, but it's not that a kid died. What did you give that kid and parents when they were alive? That's the important thing, okay? I've had many children in my cardiac ICU die on me. It didn't mean that I didn't cry. I cried just like the parents did. They were my kids. You know, I adopted them. I was their mother while they were there in the hospital. That's how much I cared. And today, 20 years later, some of these children who've died, I'm still in contact with the parents. That's how much of a difference, again, you can make. So prognosis, it depends on what was that initial white blood count. Was it 0.01 or was it 0.01? It makes a difference. How old were they? And in leukemia, you've heard there's leukocytic and myelolytic, ALL, AML leukemias. ALL is easier to treat. AML is harder to treat, okay? So that's the difference there. Boys or girls make a difference. And type of your blood. If you have a very rare blood type, you're going to be getting blood transfusions, platelet transfusions. And if you don't have blood, you're going to bleed out. And those could be the complications that kill you. So if you're A positive, you're all right. But if you're AB negative or some crazy one, it's going to be harder to treat you. And we're going to go into a child with cancer. So cancer, how do we treat it? Well, it could be chemo, radiation, surgery, all these different things. We know that cancer is going to look something like leukemia, right? It's going to have pain, fever, bruising, could be that petechiae, because that's those platelets, right? And just bleeding. And then, of course, you have no hemoglobin hematocrit, so lethargy, weight loss, lymph nodes are going to be swollen because you're not fighting any infections. And sometimes you can see the visions changing. Now, when we're giving chemotherapy to children, we know that we're knocking out their complete immune system because we want to knock out every white blood cell because it may be carrying that cancer. So there is something called a neutrophil count, something that nurses should be looking at because priority care depends on neutrophil counts. So you can have children with fevers and sore throats and vomiting and this and that. But if they also have a neutrophil count of less 500 or less, that's your first patient you want to see. That's a patient who is the sickest in your unit, okay? Now, when we are looking for septic shock, that's the first thing we look at is the neutrophil count. And then, of course, we're going to be collecting all of those cultures. You have a fever, we're going to culture everything. We know that. We're going to do sputum, blood, urine, everything. We're going to see where is this fever coming from. And then we're going to put them on broad spectrum antibiotics. And as a nurse, your priority, hand washing and a mask, because you don't want to spread infection. Hand washing is always number one, prevention of infection. As I said, you're going to have low blood counts, and those platelets are the big thing. We're going to be monitoring those platelet counts. And if this child is at home with these low platelet counts, they shouldn't be outside playing soccer, baseball, swinging off of a tree, riding a bike, areas where they could hurt themselves and, bump themselves and cause bleeding. We know that in cancer, that because we're killing cells, anemia is extremely common. And we know that we're going to see these kids are going to be tired and they're not going to have a lot of energy. So provide rest breaks for them. Nausea, vomiting. Now, we used to, believe it or not, years ago, I couldn't give an antiemetic until they vomited. Well, thank goodness today, we know they're going to vomit. So let's give the medicine before we give the therapy. Now, today, they are using these synthetic cannabinoids. I've been very interested in this and saw many documentaries about it. Netflix has a great one out there that I just recently watched about these cannabinoid oils and giving it to them and how they were able to eat and function. They use it in seizures also, I've seen been done. It's controversial, of course, but if it helps your kid get through treatment, if it helps your kid stop seizures, it's homeopathic. So if it works, but that's everybody's own decision. We know they're not going to be able to eat because they feel nauseous, they feel terrible. But again, putting them on a high protein, high calorie, full fat, everything as we can, all right? Try to get as much nutrients with the smaller amounts of food will help. And we monitor nutrition how? Are they getting enough? Let's look at their height. Are they growing? Because they're not if they're not getting nutrition. How's their weight? Are they gaining weight? That's showing they're getting proper nutrition. Height and weight monitors nutrition in every single way. The first thing that you should be aware of in your assessment. You have a child that's going through whatever, chemotherapy, height and weight. Let's see, are you gaining weight? Are you getting taller? Okay, you're getting nutrition. If not, stress nutrition and how to feed the child. We know sometimes their mouth gets full of ulcers, so we really need to take care of their mouth because they're not going to want to put food in there if it hurts. And it goes from not the mouth, it's the whole GI system. It's the mouth to anus, can be all irritated. So nausea, vomiting, diarrhea, even the rectal area could be hurting to stool. So being aware of this and giving them foods that they need and maybe small, frequent feeds, maybe sitz baths, right? Now, they say to avoid viscous lidocaine. It'd be the easiest, numb the mouth, let them eat, right? But they're going to choke, and then they could aspirate, and that could be more of an issue. We know sometimes it gets into that neurological thing. Now, many times if you're not eating a lot, you're not going to have nice soft stools. So you're going to be constipated, right? What do you do when you're constipated and you know it's there and it needs to come out? You push down hard. What can that do? It can cause a stroke, especially if you have low platelets, if you have low hemoglobin hematocrit, you're more apt for stroke. So make sure that we give stool softeners to these kids so that they can stool easier. You know, again, pain medicine as needed, but remember with pain medicine comes constipation. So make sure we give stool softeners too. They can have blood in their urine. I mean, come on, you're having bleeding coagulopathies with cancers. And they can lose their hair. I mean, I've seen other brothers, fathers, shave their heads with the kids. I used to have bows, ribbons. I would go get these little spools of ribbon, all different colors. And on little girls, I would put ribbons. I said, well, what color are we going to be today? You want to be yellow, or you want yellow and blue, yellow and green? And we'd make rainbow ribbons. So even if they had no hair, if it was falling out, they felt pretty because they had this ribbon that they made that they're proud of, that they put on. So there's a way to deal with these things. We do give steroids a lot to these children. Remember, it can cause a lot of weight gain. On the smaller kids, they don't see it as much, but the older kids, remember, body image to those adolescents. So make sure that to prevent it from getting too bad, we work on the salt. Because that can decrease that fluid. And then, you know, if there are different size gowns, and in pediatrics there are, make sure they have one big enough so they don't feel like all squinched up, or have the parents buy a size larger so of their own jammies so that they don't feel like tight and, you know, into this jammies. You know how it is to have a shirt that's too tight, you feel so uncomfortable, and you keep pulling on it. I mean, these kids feel the same way. Preparing them for procedures. Now, many of these things like bone marrow, lumbar punctures, many of them will give them something like midazolam, Versed, it's a sedative, so that they're floating around a little bit. Also, you know, getting involved with child life, having them there, getting them prepared, using numbing creams. EMLA, it's a great one. You know, it's a cream, you put an opsite on it, let it sit there, and then they don't feel the needle going right in. And then I've actually done lumbar punctures saying, I'm going to give you the biggest hug, and you're going to feel touching on your back. And just don't move, just let me just hug you all over. And then mommy would be there too, and they'd be also looking at maybe child life with a, you know, a video, maybe a game, a something to keep them distracted. And boom, boom, it's done. And that's it, because they were prepared properly. And then again, I can't emphasize, you know, pain management's just not an opioid. Remember, Tylenol works well on children. You may not give Motrin because it has something to do with those platelet coagulopathies, okay? But Tylenol for sure. And remember positioning, ice packs, cold packs, turning them on their sides, maybe rubbing their butt, you know, because they're getting tender. All of these things, elevating the head of the bed, those things help along with, and then of course, distraction on the kids. You know, putting an iPad with a game, these kids forget what's going on, putting on their favorite cartoons, playing a game, having them coloring a picture, all of this stuff helps. Now, there's lymphomas. Remember, lymphomas are the lymph nodes, okay? We know that there shouldn't be felt in a normal kid, right? Healthy kid, you shouldn't feel anything. But with a kid who has Hodgkin's or non-Hodgkin's, they're going to be there somehow. Now, let me tell you the difference. Now, Hodgkin lymphoma goes to the lymph nodes. You're going to see these big things like these pictures. They are painless, enlarged, and it's usually above the head, okay? Above the clavicles. So up here somewhere, you're going to see enlarged, glands. That usually brings these kids to the doctor, is that they'll see. And of course, they've had a fever, and you'll see this. And of course, what do kids do when they don't feel good? They don't eat. They call it anorexia. Now, Hodgkin's, only above, the clavicles, big nodes, they don't hurt. How do we diagnose things? Well, history physical, let's see what the symptoms are. A CBC, let's see where their blood counts are. The CRP and ESR. Now, a CRP is a C-reactive protein. When that is elevated, it shows signs of inflammation. You actually look for that in rheumatoid arthritis too, because it's inflamed. Do that in lupus too. ESR is a sedimentation rate. Again, shows signs of inflammation. If it's elevated, something's going on in the immune system. And then, of course, alkaline phosphatase, urine, x-rays, we want to see what these nodes look like. And if we see a big node like that, do a biopsy. Of course, these kids will be sedated. Sometimes they even take them to the OR to give them really good knockout so that they can get a good biopsy. And they will see Sternberg-Reed cells. How do we treat Hodgkin's disease? Well, it's a cancer. Chemotherapy. Sometimes if you just have a big one, they might do radiation, but usually it's chemo. These kids do great. These kids do really good. Again, kids, what do we need as nurses to do? Well, prepare them. Let them know what's going to go on. They don't need to be frightened of maybe that X-ray, that CAT scan, that big circle, that noise, whatever. Those blood tests, make sure they know, okay? Have them prepared for all those side effects I talked about already, so that the child knows and the parents know what they can do and how they can help, because parents want to help. The problem with Hodgkin's disease is you usually become infertile. That's the biggest downside of Hodgkin's. Now, do you see that little mark on the skin? That is what we call a mark for radiation. Never wash it off until radiation is done. That shows the machine where to point the gun, so that they can give it in the proper place, okay? Now, non-Hodgkin's, what's the difference? Well, it's lymph nodes everywhere and it's diffusely spread and you really don't feel it. Hodgkin's, big, enlarged, non-tender nodes above the clavicles. Non-Hodgkin's is all over the place, okay? So what do you see? Well, depends on where it's at, what you see. Many times it does metastasize to the bone and it might look like leukemia. Again, we're going to do a biopsy. We're going to find out where a node is and try to get that to confirm that disease. Again, we're going to do bone marrow, looking at their cells, see what's on, looking at their body, seeing where this is all metastasized to. Again, we are going to do aggressive irradiation chemotherapy, induction, right? Where we want to get to remission in that first 4 to 6 weeks. Sounds like leukemia, right? Consolidation, maintenance, and then some intrathecal. Again, it takes a while, but we can cure it. It's harder than Hodgkin's. Now, brain tumors. Most common solid tumor in a child. It doesn't have to be malignant, but it's still something occupying space in the brain. So what do you see with a child with a brain tumor? Well, you have something in the head, it's swelling, taking up space. You're going to have headaches that are going to be progressively worse and worse. they're going to become longer and harder to treat. Also, they're going to start with the pressure in the head. They're going to be vomiting, not related to eating at all, not relating to eating at all. And these headaches will wake them up out of a dead sleep. That's how bad they are. So how do we treat these? Once we've gone in, we've done the CAT scan, the MRI, we see where it's at, we made a decision. We're going to do usually radiotherapy to shrink it, because we have to remove all that tissue if we can, if it's in a place that's operable. We want it tiny because we don't want to take out brain tissue because it may affect hearing, speech, balance. It could affect memory, anything. I mean, our brain does a lot of stuff up there. Then we might do chemo with it, with radiation or not. That's depending on it. And then we'll do surgery. Remember, post-operatively, there's a space left in that head. So we need to know what position to let that child be in. Do we elevate the head? Do we lay them on that side? Don't we lay them on that side? You need to follow doctor's orders very clearly. And another thing about brain tumors, be careful with intake and output. Too much in can cause swelling in the brain, causing more problems. So we're going to worry about that positioning, fluid regulation, pain management, pain management, pain management, and supporting that family. And if they have some sort of delay in their walking or speech, put them into therapy and get them to be where they can be, their optimum level of functioning. Neuroblastoma. This is a tumor which starts usually in the abdomen. It usually is small, and then it all of a sudden, you're going to see this swelling of the eyes, and this tumor metastasizes to the brain. Usually by the time we see the tumor in the abdomen, it's already metastasized. It is very uncommon, okay? But it's usually too late by the time we know. These children, again, we try to do all of the radiation and chemo and take it out, but it depends on how far and how metastasized it is. It's not a good tumor to have. And then osteosarcoma. Osteosarcoma is a bone tumor. When we think of a bone tumor, we think of osteosarcoma, which is on the femur bone. It is usually on adolescents and more boys and girls. And it will be all of a sudden, I mean, there's been a couple football players that had these limping, and were doing good, and they had limping, and they got worse and worse. And then they find out they had osteosarcomas. And it is not a good tumor to have, because that whole bone has to come out. This is your femur, which connects your lower leg to your hip, right? It all has to come out. So with these things, you're going to see, take a picture of it. We're going to do x-rays, CTs, MRIs. We're going to do biopsies. We're going to determine what it is. And what are we going to do? How do we save this child's life? Well, as I said, that bone has to come out. What they're doing today, which I think is pretty neat. Now, if we took the whole leg off and there's nothing there, how are we going to put a prosthesis on for this child to walk? There's nothing. There's not like a below the knee or above the knee amputation. There's nothing there. That whole area has to come out. Well, today they take the lower leg and connect it to the hip. So now you have your foot and your lower leg connected. It's called limb salvage, salvaging the limb. And they can put a prosthesis on that, and these children can be more mobile because there's a place to put that prosthesis. Pretty neat, huh? Pretty sort of strange, but at least we can do something to help them. Sometimes we can't, but most of the time, this is our goal. They'll do chemo and they'll do radiation, and then we'll pull out that femur, we'll do that limb salvage, and then through therapy, we'll get that kid walking. Wilms tumor. Wilms tumor is a tumor that comes off the kidney. These are usually African-American boys ages 3 to 5. I saw one in my career. After the Haitian earthquake, I was working triage at, the area hospital, and we got this little boy in with these religious group with a pack of papers. And I said, so why is he here? And they go, I don't know. We were told to pick him up at the airport and bring him directly here. I said, okay. He spoke French. The papers were in French. I had no clue why he was there. So I need to place this kid somewhere in the ER. Is he non-emergent, emergent? Is he I need to get him now? So what did I do? Well, number one, I got the kid calm. I, gave him a sticker, did something, because I can't speak French. Okay, place was busy. I had nobody to help me at the moment. Took his vital signs. I listened to his chest, and I listened to his abdomen. And when I got to that left lower quadrant, I felt a softball-sized tumor. And I had never remembered Wilms tumor. I had no clue until that moment when I went, oh my goodness, this is a Wilms tumor. I can't touch this anymore. So now I know where to place this kid. And I placed him into the ER, and he was a Wilms tumor. You're going to find this in your career that you think you forgot this something, and you're going to see it, and something's going to flash in your brain, and you're going to remember. So history physical, this kid was in Haiti. I don't know more than that, but what did we do? Well, this big tumor, big sign up, do not touch abdomen. Why? Well, we don't even do a biopsy on it because we don't want any of those cancer tissues metastasizing in the peritoneal cavity. So when you touch it, fragments will burst off and go into the peritoneal cavity. And we don't want cancer to spread like that. So didn't do an ultrasound. We did a CAT scan and MRI. We did CBC, and we got this kid prepared for surgery. They did a little chemo. They did a little radiation on it, and then they did surgery. Now, this kid did well. It's a big, as you can see, that incision can be that big on these kids because you have to get in there. You have to make sure you don't over manipulate it. You can't pull it through a small incision because it can put the metastasis everywhere. So post-operatively, pain management, because it's the kidney, we got to watch urine output, and we had to monitor the GI tract because we manipulated it a lot during this surgery. So bowel function, urine, and of course, infection. That child did well and went back to Haiti, and that was the end of his story. But I'll never forget him because he was a challenge because I had no clue what he was. And it was only my assessment that I find what it was going on. Rhabdomyosarcoma is coming up from some place, the ear, the eye, the mouth, the nose, and you'll just see some swelling or some sort of something that doesn't look right. And these kids will be brought to the doctor. And these kids, again, they've got to do surgery and they need to remove the cancers. Retinoblastoma, I've seen one. It was actually an 8-month-old little girl. And if you look at that eye, do you see that white glow? They call it a cat's eye. Ever turn out the lights outside and there's a cat or a deer or something out, the dog, and you see this little glow of white, their eyes like that? Well, one of their eyes will look like that. There's a tumor in the retina. It's that whitish glow that's there. And, these children, awake alert, they don't know what's going on. Now, how do we treat it? Well, again, there's that radiation mark. Don't touch it, leave it there. Chemo, and then they're going to put in some implants to shrink it up as much as possible. They will take the whole eye out. They have to, because it's the cancer. Now, as you are collecting data regarding this child, get a detailed family history about any eye signs and symptoms, about this child. When did they start to see it? When did you notice? Because these will metastasize. So it will tell us, no, I just noticed it last week and I brought him in because it didn't look right. And okay, we caught it early. So we only have the eye. Yes, they take the eye out. It is, horrific that happens, but they do put these prostheses in. I remember a kid in high school who used to take his eye out and roll it around the desk and put it in his mouth and pop it in. I thought it was the most disgusting thing I ever saw. Why did he do that? But you know how kids are, especially adolescents. And he was a boy, he wanted to make all the girls go, ugh. Well, he did. Thank God I always wanted to be a nurse, right? Again, support these parents because they're going to go through a lot. Germ cell tumors. Well, I think of germ cell tumors. These are your 15 to 19-year-olds. And a lot of times these are testicular cancers. I've got a story about an 18-year-old. 18-year-old came into the ER, into the triage, complaining of testicular pain, which any boy complaining of testicular pain is an emergency, and they get pulled into triage first because it could be a twist, a torsion. And we need to save that testicle so they can have children, right? That's our thing. Well, I was in the room with another nurse who had the boy, and she said, well, pull down your pants, let me look. She put gloves on. One testicle was the size of a softball. She goes, oh boy. Anyway, we put him in the back and they did an ultrasound, urine, and they did a chest x-ray. This kid already had metastasized. He apparently had this enlarged testicle for, he said it was a month. Well, probably it was a couple months. It spread that quick. And about 3 months later, he died. I did know that his girlfriend was pregnant, so at least his legacy was carried on, if you want to look at it that way, but baby was born without a father. So it's whatever way you want to look at it. But testicular cancer, you have pain in your testicles, just like women check their breasts, men should check their testicles monthly. Liver tumors, well, livers are great. You can get a piece of a liver and it will regenerate. You can take a piece of a liver out and not take the whole thing out and it will regenerate. Yes, it is a huge surgery. They have to, you see, again, this is an accurate liver transplant type of resection and an incision there. They do chemo, they'll take it out, and usually the kids do really well. So what is our survival rate? Well, I've been a nurse now for, oh my God, 46 years, or is it 47? I don't know, it's been a really, really long time. And I know years ago, we didn't save as much as we do today, but I know we're at least at 80%, if not more, since this book. I know advances in the cardiac are amazing from just 20 years ago, from 20 years before. So I know that it's probably more than 80%. As long as you get early intervention, you do the treatment, you follow through. And I know that these kids today are having better survivability. So love these Facebook pictures when you see a kid or an adult cancer-free. I think it's the best feeling in life. Cancer's not nice. And it's a hard fight to go through. Any questions? A lot of stuff there. Who wants to win a Cahoots today? Nobody? Shannon, come on, Esther, you do. I know you do. I know you do. Douglas, come on, it's your turn. Brianna, come on. We got to do it today. I might run a little bit over if I don't talk quick enough. I just had a lot of stories to tell you today. And I think the stories do help. It helps you understand it a little bit better. So remember to get yourself to a review this week. Make sure you listen. I think I had over 600 listens on my exam one review. 600. That's telling me you guys are working really hard. All right, I'm going to get going because I know we're running late. Which statement best describes a neuroblastoma? Remember, this is the one that starts in the abdomen, and then it passes the midline and gets really big, and then you start seeing symptoms in the head. And it is usually after metastasis that the diagnosis is made. So it starts in the belly, goes to the head, but it's already too late. What is priority treatment for a newborn of an HIV positive mother? What is our goal? What do we have to do? So remember, HIV is a virus. We're going to give antivirals at 22 weeks of pregnancy. And our goal is to improve that infant's immune system. What are symptoms of sickle cell anemia? When those cells get stuck in some vessel they can't get through, they back up, it swells. What do you see? So we're going to see hand, foot, wherever swelling, pain. You can see vision, delayed growth if it's going on. And remember, there could be a stroke. There could be a headache there too. Sickle cell anemia affects which cells? I'm making sure that you know. Red blood cells, good. You'd be surprised sometimes, not everybody says that. What kind of hematocrit would somebody with sickle cell have, and why? Is it high? Is it low? What is it? Excuse me. Remember, these blood cells die quickly. They can't keep up with it. That's why they always come in with low hemoglobin hematocrit. So lower, their cells die quickly. What is the treatment for sickle cell anemia? What did I tell you was number one? You got to block up in the blood vessel. That pipe ain't flowing, right? Number one, IV fluids, pain medicine at usually the same time, blood transfusions, and a bone marrow transplant if we can. What is the reason children with iron deficient anemia are easily tired? You're just missing iron, right? What does that mean? Iron deficient anemia, you don't have enough red blood cells, you're not carrying oxygen around or iron, so they have no energy and no oxygen, so they tire easily. Aplastic anemia includes a depression of which cells? So it's all the cells, red blood cells, white blood cells, platelets. So what do many of these children need? Is blood transfusions, right? In order to keep up with it. Most common type of anemia is iron deficient anemia. It's the most common, and how do we correct it? Diet and maybe some iron medication. What causes pernicious anemia? Well, this is a nutritional. What is pernicious anemia? Which deficiency? B12, intrinsic factor. Excellent. Good job. What symptom is the single most common symptom of anemia? I mean, this was what brings them in usually to the ER or to the doctor. This ain't normal. It's not my kid. And it's fatigue, tired, no energy, pale. You might even hear that murmur going on, right? The swishing of blood. When teaching parents about beta thalassemia, the nurse informs that the child is at risk for what? Remember, thalassemia are those little rectangular cells that burst. Their lives are short, they're born, and they're bursting. What's inside of that cell? It is oxygen is in that cell that's dying. There's not many cells. And iron and oxygen are gone in the cells. That means you're in iron overload. You need medications or you need apheresis. Beta thalassemia, the treatment for Cooley's thalassemia is blood transfusions or maybe a transplant on these kids. What lab values will you see with hemophilia? I mean, yeah, you're going to see some sort of factor missing, but all of those other normal labs, what do you see? PTT is prolonged. You look like you're bleeding, like heparin, right? Thin blood, bleeding heparin, it looks like. PT platelets, they're normal. So what do? We find out which factor and we give it, and we protect the joints. Priority treatment for a child with sickle cell crisis is first thing, priority. IV fluids, and then pain medicines. And why not pain medicine first? You're treating the symptom, treat the cause. It's a block up. Blood can't get through. Dilate the vessels, get those cells going, and give the pain medicine at the same time. But IV fluids, priority. What is immune thrombocytopenia purpura? ITP. What is P? It'll help you remember. It's low platelets. Simple as that. ITP, P, platelets. Remember, ITP, all we need to do is correct that immune issue that's going on, right? You'll see that bruising, maybe a nosebleed going on. Thrombocytopenia could cause the following symptoms. Remember, thrombocytopenia, ITP, is all about platelets. Platelets deal with what? Bleeding coagulopathies. If you don't have enough, what do you see? Bleeding, hemorrhage, ecchymosis, and epistaxis. Very good. I'll multi-select. A child with hemophilia has fallen and knee is swollen, painful. Treatment would include what? Well, you got to think, what is hemophilia? That's a bleeding problem. They've fallen and that knee is swollen. Why is it swollen? How are you going to prevent damage? Well, rice. So you're going to rest, ice, contain, and elevate it. And we are not going to exercise it. That would create more bleeding. Hot packs, you're dilating it. You're causing it to bleed. So cold and elevate are the ones here. What is the priority nursing action for a suspected blood transfusion reaction? What do you do first? Get all of a sudden spikes of fever. Turn it off. Absolutely. A child is admitted with neutropenia. What nursing action takes priority? What is neutropenia? What does that mean? So neutropenia is low white blood cells, which means their immune system is not as strong as it should. So nurses, wash your hands. As simple as wash your hands. All the other stuff is not needed. Priority, wash hands. Visitors, wash hands. Which symptom would a healthcare professional expect to see with a child with leukemia? Well, what did my next door neighbor, that young girl, go in with? Bruise. Well, remember, when we look for a child that has possible leukemia, okay, remember that this child has a low white cell and usually will have a low platelets. It's just part of trying to fight the infection, trying to fight what's going on. So you're going to see bruising because of this extra blood thinness, fatigue because their red blood cells are not good, and then their bones hurt. So we're going to do that CBC and a blood smear first, see what's going on. Your child with leukemia has recent lab results with platelet counts of 10,000. Nursing action. What does a platelet count of 10,000 mean? What do you have to be worried about? Or do you have to be worried? So we know that platelets do affect bleeding. So bleeding precautions, no IM injections, soft toothbrushes. We're going to be monitoring those lab values. You know, these are very, very things that we can do that some nurses don't even think about. Giving an IM injection could cause a lot of bleeding, cause more problems. A multi-select. Child's placed on bleeding precautions for ITB. What interventions would the nurse do? Remember, ITP is platelets, bleeding precautions. Oh, we've already put them on the bleeding precautions. No injections, monitor the CBC, always looking urine, stool, mouth, whatever for bleeding. And then again, as I said with the PowerPoint, corticosteroids are used if they're really symptomatic, and they are used well. They can give the anti-IVIG, and they can give anti-D also. A child with a Wilms tumor, which action by a nursing student causes a faculty member to intervene. What did I tell you about that little boy with that Wilms tumor? Do not touch that belly because it can throw off little little metastasis into the belly. We don't want that. Cancer of the body's blood-forming tissues, including the bone marrow, is caused what? And it's called leukemia. Good. A child with ALL has a fever of 100.5. What should they do? What do you know about leukemia? What does it affect? It affects the white blood cells. What do white blood cells do? They help with infection. If you don't have white blood cells, you need to get this kid to the doctor immediately. In fact, you'll see children with cancer. If they have a fever, and 100.5 is the number they always use. Fever of 100.5 or higher, seek medical attention immediately. This child has no immune system and could go into septic shock quickly. They need to be placed on antibiotics as soon as possible. Child is having a bone marrow aspiration. What should you tell the child? I don't know if you've ever seen a bone marrow aspiration, but you actually hear crunching of bones as they get that syringe in there. It will hurt a little. We'll try to do everything possible. And they're really, really getting good about pain control today with that. Most common clinical manifestation of a retinoblastoma. And it's that cat's eye. Remember, retino is that cancer of the eye and the pupil, and you'll see that white thing. It's like seeing a cat in the like that whitish glow. It's called, or cat's eye reflex. It's called both. Your child has been diagnosed with a retinoblastoma. What information is important? When you're taking your history, you're taking your assessment, what is something that's going to tell you how you're going to treat this child? I want a history about any eye signs and any symptoms seen. I want to know when it first was seen, so I know, has it had a chance to metastasize yet? And that will tell us what do we need to do for our course of treatment, how much investigation is needed. A goal of surgery for a child with an osteosarcoma is what? Remember, an osteosarcoma, bone cancer, is the femur bone. So we want to salvage the lower leg and put it up so that we have somewhere so we can attach a prosthesis so this child can become mobile. Immunizations causes autism. Yes, no, maybe so. No, there was a study that came out many years ago by a physician, which has been deemed as an invalid research study. This physician's license has been taken away. There is no correlation. What happened was they felt the chickenpox vaccine caused it, because that's about when we diagnose autism, about ages 2 to 3. And we usually give chickenpox vaccine, the varicella, right around 2 years old. So they felt that that caused it. No, it doesn't. A child's complaining about skin markings for radiation therapy should be told what? The little purple markings that they do. It's where they zap that radiation gun. Leave it there. It has to stay there until it's done because we want to know exactly where to shoot that ray so that we're giving the same amount of radiation to the same place. A multi-select. Nursing care of a patient with immune thrombocytopenia purpura, ITP, is what? P, platelets, right? Low platelets. What do we worry about with low platelets? Bleeding precautions, right? No IM injections. We're going to monitor those CB seeds and we're going to give corticosteroids as needed. Now, this has no blocking of the blood system. There's nothing that's blocked, nothing that needs to be opened. You do not need IV fluids, okay? This is a common error of students to put IV fluids for ITP. You don't need them. That's for sickle cell. You want to unblock the blockage. There is none here. You just have platelets, you have little petechiae, and you have some bleeding going on. There's no blockage. When distraction is used, it helps what? All of the above. And then when you do distraction, they forget about why they're there, pain, everything, because they're having fun doing something. And even for a little bit, it helps. What assessment question needs to be asked to a child with possible rheumatic fever? As I always say, I do go back to last week, and I will ask you some questions. Any sore throats, right? Because strep causes rheumatic fever. How do we treat rheumatic fever? I mean, remember, rheumatic fever can go to the point where you're on that unsteady gait called chorea, and it can affect those heart valves. As long as we get it before it has attacked the heart, we can get rid of all the other symptoms, and we treat it like a strep infection, long-term antibiotics. Could be a month, could be 2 months. Signs and symptoms of asthma. Coughing, shortness of breath, expiratory wheezing. Remember, not inspiratory, expiratory. Croup is inspiratory. Asthma is expiratory. It's all of them. Good job. Multi-select. What symptoms should be reported to a healthcare provider for a child with sickle cell disease? Sores are not sickle cell, okay? The swelling, they can have chest pain with it. Could be, something that feels like a pulmonary embolus, which is chest pain. Headache, remember that could be the stroke. And of course, the swelling with the blocking of that. First treatment for sickle cell, IV fluids. Absolute contraindication for nasal suctioning include which of the following? I mean, if you look at all of those things there, they all have to do with the oral airway, and they all have to do with swelling that's been gone there. So we're not going to do it for any of those things. We don't want to increase any swelling when our airway is already compromised. Iron dextran is given via which route? This is something we give with Cooley's thalassemia because of that iron, it's given for iron deficient anemia for those children who have low iron and they don't want to eat the iron stuff. And it's IM Z-Track. It is thick, it burns, and it stains the skin. So Z-Track, as you lift the skin up, put it in, pull it out, it's what I call a lock and load, which means the medicine can't come out, stay in the skin. and it does better with burning too. A child was to receive their own bone marrow. This is called a blank transfusion. And it's called automatic, right? Autologous, automatically mine. It's okay. Remember, all is everybody's. That's everybody else's. Good job. You remembered. What cancer may present with painless, firm, and enlarged cervical nodes? Means up here. That's Hodgkin's lymphoma. Remember, non-Hodgkin's is everywhere else and all over the place, and it's hard to see. Hodgkin's, you can see them sticking out. And we'll do a biopsy of the node and look for Stern-Riddig cells. A multi-select. What teaching about sickle cell disease you would include? So child just learned they have sickle cell, or they're chronically having issues. What's some of the teaching that you would do before letting them go home? So we're going to give a lot of fluids, right? Because we need to keep those pipes open. Dress warm, because we don't want to make those vessels small, which could cause sickle. Pain medicine, early symptoms, and any fever, 100.5 or greater, we need to treat with antibiotics, get medical attention. Thalassemia major is treated primarily with what? Remember, those are rectangle cells that burst. They're very short-lived red blood cells. And the treatment? Blood transfusions. Blood transfusions is what we do for these. There's no red blood cells. We got to give them. A multi-select. What are opportunistic infections of HIV? Candida, yeast, okay, and then PCP pneumonia. Those are the two. UTI rashes, no, that is not opportunistic. Candida and the PCP are those opportunistic. A multi-select. Treatment of osteosarcoma includes we know what we want, what the goal is, but this is all the possibilities here. Amputation, we don't want to, but sometimes we have to. Chemotherapy, and we want to salvage the limb. Excuse me. In this case, stem cell does nothing. It has nothing to do with blood cells. This is a cancer of a bone, so stem cell doesn't work. A multi-select. Who are the best donors for bone marrow transplantation? I mean, as I said, could be a little bit of anybody with stem cells, right? Bone marrow. It's either siblings, which is anybody, or yourself. Those are actually the two best. I mean, number one, of course, will always be yourself if you have that. But if not, a sibling is actually the second best one. It's a little bit of both, right? What is the most common opportunistic infection for children with HIV? I remember when I first saw this, it was the beginning of HIV. I was working at a county hospital. I went in as an agency nurse into the medical ER, and I had a patient crash. And they said, "Oh, he has PCP pneumonia." And I went, "What is that?" This is in the middle, like about 85, 86. This is when HIV just came about. I was like, "Well, what does that mean?" So I had to look it up. PCP pneumonia, most common. What would you consider to be neutropenia or low neutrophil count in children? Now, I talked about a patient with neutropenia or a low neutrophil count. Where was that number? Normal neutrophil count is well over 1,000, okay? Closer to 2,000. Less than 500, this is a child who is up to go into septic shock. There is no immune system. This is your priority patient right there. You ever see that low neutrophil count? Number one person. A primary characteristic of a brain tumor is remember, brain tumors, it could be cancerous or not. Remember, they're occupying space and they're growing slower or quick. Could be either. But their symptoms get worse over time. Headaches, could be some headaches that get worse. Vomiting, not related to eating. Occasional headaches, no. Headaches all the time that get worse and worse and worse and worser. The optimum treatment for osteosarcoma is what? What did I tell you we want to do? Remember, osteosarcoma is removal of the femur bone. I mean, what are we left with? We want to salvage that limb. We want to take the lower limb, put it up so we connect some sort of device that they can walk. I mean, that is what we want. And these are a lot of times adolescents. Can you imagine not being able to get around in a wheelchair? They want to put on some sort of prosthesis and they want to be able to move. And last question. A child is receiving the induction of chemotherapy. What does that mean? Remember, there's 4 stages of chemotherapy. Induction is the first stage, and the goal is remission. And after that, it's just getting those little pieces of cells that just don't work, you know, that are bad. We want to get rid of them. Number 3, M&M. Number 2, KV. Number 1, Kel. Good job, guys. Ashley and Victoria, good job, guys. Let me get us out of here. Please sign your attendance attestations. Get them done and out of the way. You guys actually been very good, and I appreciate that. Remember this week that you do have your exam reviews. Next week will be exam. Come on your phones and make sure everything is plugged in and ready to go. Anybody have any questions, let me know, and I will be there to help you, okay? Thank you, guys. Have a great day.
Thank you, you too.
Always my pleasure.
Thank you.
Thank you.
Thank you.